I chose the topic life after transplant because I think once you've had a transplant, you're kind of living the life after transplant. I initially made this talk for a group of nutritionists who are focused on kidney patients, but some stuff will apply and some slides I'm just going to skip. All right, so we're going to talk about three different things. One is the variability in patient experience in the first 3 months after transplant. And I think if you have gone through transplant, you probably, and talked to some other people, you probably heard stories that are as different from, I had a kidney transplant. I was in the hospital for 2 days. I went home and I did great. And then on the other hand, there are stories of, man, I got a transplant and the first one didn't work. And then I needed another second liver while I was still there and that didn't work. And then finally the third one took, and here I am after months in the ICU and a long course of rehab, right? We've all been there. We've all had our own stories. And I tell everyone that there's a path for everyone. It's never the same. For kidneys, I had focused then on describing differences in outcomes by donor organ quality, and I'm going to expand that a little bit for liver in case you ever need another organ. And then I looked at, different options for kidney donors, but because there's just differences, but they affect how things go after transplant. All right, so I have a couple disclosures. I'm on the board of the National Kidney Foundation, Maryland and Delaware as a board member. I'm a transplant recipient. I'm a transplant surgeon. I'm a female. I'm a mother. I'm a wife. I wear many hats. I serve as a consultant for Memo Therapeutics, but they do stuff that doesn't really relate to this talk. So for kidney patients, kidney disease is common, right? 1 in 7 people have kidney disease. That's a lot of people. It may be many of you, 1 in 7, maybe a little more common if you're taking some medicines, calcineurin inhibitors, you have other issues. Kidney disease becomes more common as people get older, and 38%, that's close to half of people over 65 will have some amount of chronic kidney disease. It can be very mild and not affect really much of anything. In Maryland, we do a lot of kidney transplants, right? We have a few different transplant centers. We do between 70 and 200 living donors a year, 10 to 50 kidney and pancreas transplants per year, and 350 to 550 kidney transplants per year just from overall deceased donors, living donors, and whatnot. When you're a patient in the hospital, and a lot of you have been there, right? For kidney transplant patients, I tell most people that most people will spend now 2 to 5 days in the hospital. I remember back in 1988, I must have been in the hospital for 2 weeks, 3 weeks after my transplant, right? The catheter stayed in for 10 days and nothing moved fast. And I think everything has changed a lot. So the time in the hospital is not long. I think the fastest liver patient I've ever seen discharged after a liver transplant was 4 days. The pancreas, the fastest, again, 4 days. Hearts and lungs, I don't honestly do. I stay out of the chest as much as I can. I don't know what I'm doing in there. I get a little lost and confused. So, but again, the hospital course can be very different, right? And we all know that in the beginning, there's very often frequent weekly visits, blood draws, and then it gets better and better. And many patients after 1 to 3 years only need blood draws every 2 to 3 months and a visit every year. I think for different organs like liver, that may even be less frequent once things are really stable. So it's pretty awesome when you get to a good point. This is me. You can see part of me. Me having my second transplant, actually. So there's no HIPAA violation. I can show a picture from the operating room because I am the patient. There's my fellow, my doctor, Dr. Schweitzer. Some of you may know him, Vanessa, our scrub tech. And this is sort of what it looks like, right, in real life when people are working and a transplant is happening. So obviously, all transplants are done under general anesthesia, right? We don't do it under local. Most of us have a catheter in our bladder, when we wake up to measure the urine output, see how we are. And I think in general, unless you get a heart or a lung or a liver and you're in the ICU, even then, I think most units are very focused on getting us up to the chair after just a few hours of being awake and up and walking as soon as we can. And I think those in the past have been undervalued and we left people just lying in bed. But whenever you're lying in bed in the hospital, you end up losing a lot of muscle mass. And so lying in bed for a day and not moving is really bad for your overall health and your recovery. So the best thing you can do if you're in the hospital is try not to lie in bed and try not to stay in your room. Granted, for the last few years, that was kind of almost impossible, right, with COVID. But now I think even if I was in the hospital, I'd plop a mask on and start walking laps as much as possible. It prevents pneumonia, it prevents blood clots, it prevents loss of muscle and strength, and it can keep you out of a nursing home by being active. So I think that's important both every day in life. It's also important, especially when you're sick, because that's when your health can decline rapidly. And then ideally, I tell people home 2 to 5 days later. I think the 3 things that keep people in the hospital longer than any of us normally need to be in the hospital are our blood pressure, our blood sugar, and learning or knowing new medications. So I kind of, would look at it as if you're in the hospital and you're figuring out what's keeping you there, at least make sure every day, if your blood pressure is high, someone's checking it and adjusting things. If your blood sugar is high, someone's checking it and adjusting things. And if you don't know what meds they're giving you, pester everyone who comes in and feeds you something. Go, what is it and what does it do? And why do I need it? What is it and what does it do? And why do I need it? Because the faster we learn, the better we can help ourselves, the more intelligent questions we can ask, but it's just good strategy. After the first transplant, I tell everyone that, your initial recovery after a transplant, if you've never had one yet, is kind of a busy time, right? And I say basically when you come home from the transplant, you're going to have a full-time job for about the first 3 months. And that full-time job is just learning to take care of your kidneys, okay? Or of your liver, or of your heart, or of your lung, right? And so for kidney patients, we're very focused on vitals, right? Making sure we don't have fevers or a heart rate that's out of order, or, keeping track of how much we drink, how much we pee, right? Checking blood sugars if they've been a little edgy in the hospital. And that can all be 4 times a day or more often, right? And so just to do that, you have to focus and pay attention. And then you have to come in the beginning for blood work. Then it goes to twice a month, then it goes to every month, and then it goes to every 3 months. Now, I think one thing that I've learned over time that's been really, really hard in terms of busyness, and one thing that still keeps me busy, is this last point of making sure you don't run out of meds, right? I'm going to do an interactive little thing here. I'm going to stop sharing my screen for a second. Now raise your hand, like virtually or with the reaction hand raise. There's a raise hand button, right? Raise your hand like that. If you get medicines, all of your medicines from the same pharmacy. All right. We have some lucky ones. Good. I have 3 pharmacies where my meds come from. So my life is chaotic. So some of you are lucky. All right. Lower your hands. Let's see. Let's do the smiley face. Okay. There's no smiley face. Let's do the heart. Let's do the heart. If you get all of your medicines refilled once a year, and you only have to call the doctor once a year, and everything else comes to you automatically. Nobody? All right. You're all having to keep track of what medicines are running out, what month, and when to refill it, and when to call for a refill and whatnot, right? All right. You love it, right? Such a terrible system. It makes me crazy. And I think I've come to learn that, we as doctors call a lot of patients non-compliant. When you're not non-compliant, you have a really tough job to do, right? Because the logistics of what runs out when and what needs to be refilled when, and then for many of us, what pharmacy it came from to get it refilled. That's also a pretty busy job. And I think people just don't appreciate how that really goes. Let's see if that'll go back there. Will it? Yep, there you go. All right. So we know that this is a big job. And I think, when we talk to people who've not had their transplant yet, explaining that can be really important, makes a difference to them. Okay. Complications. I think we all know that there are complications that can happen after transplant. And I tell everyone that rejection is actually not the most common thing that happens anymore. We have good immunosuppression now. Only about 10% of people get rejection. Many times it's related to, not being able to afford meds or get meds or refill meds on time. For the kidney, the creatinine goes up, or there's protein in the urine, and those are signs. For the liver numbers go up, right? For other things, other numbers go up, right? In lung, you may not be able to breathe. In heart, I know the symptoms are very, very difficult, right? To find. So the heart transplant patients go for routine biopsies. from time to time. Yeah, my health insurance only allows 90-day refills too on some meds when I'm lucky. And some of them come automatically. They get shipped right automatically every 90 days. And others you have to call to say, please, no, I'm still taking this. I need it. And those are usually the expensive immunosuppression. I'm like, that's the one you want to send automatically. So it's very counterproductive. So, oh, wow. Jennifer Hazard has it figured out. She has a helpful pharmacist. Good. That's cool. All right. And let's see. So rejection can be one problem that people have, right? And then I tell the residents and the fellows in kidney, it's the ureter that often leaks or strictures, and it's the connection between the kidney and the bladder, right? That urine travels through. And that's because the blood flow there is not always awesome. And it's also because the kidney and the bladder's not always sterile, right? We get urinary infections. And so when there's an infection, things don't always heal great. Same with the liver, right? The liver has a bile duct that's also in one way connected to the outside world because it drains into the bowel, and the bowel's not sterile on the inside either. And so the bile duct can get infections and leaks and strictures, right? In the lung, it's the trachea, again, connected to the outside world. In the pancreas, it's the pancreatic duct that goes via a piece of bowel and gets sewn to sewn. So it's quite fascinating, right? And I think the heart is lucky in the sense that they don't have anything that drains to the outside, right? So there's just blood vessel in, blood vessel out, blood vessel in, blood vessel out, and that's the heart. So I'm a little jealous of the heart surgeons sometimes because they don't have to deal with this. All right, lots of great comments in the chat, y'all. So that way you have like all sorts of very, very different pharmacies that are helpful and what helps. So yeah, and Harold says it was really hard to stop checking blood sugar. I know. It's the changes are pronounced sometimes. So, all right. Perfect. So other things that happen are urinary infections. We put catheters in people, so that happens. Wound infections, leg swelling, blood clots or fluid collections that form. And I tell patients that basically anything that can go wrong will go wrong. We just hope it doesn't go wrong in you. But if it does, we've probably seen it and we'll go from there, right? So that's a lot of times how it goes. Now, Mary, did you have a question or is your hand just still stuck up like mine? My hand just got stuck up. All right, perfect. That's just making sure. I don't want to ignore anyone. All right, so there we go. All right. So I told people at the other meeting about some, different patient experiences. So patient Austin, right, had kidney failure from IgA nephropathy, had a lot of good family members, got a living donor kidney from his brother. The kidney worked immediately. He never did dialysis. He went home post-op day 2, did great, and is happy as a clam because everything happened to work out. That's totally nice. So, patient B, I called him Beaver. He worked hard, had to work a little harder. You can see sweat in there. Kidney failure was from diabetes. Diabetes comes with a lot of other health problems. Friends and family couldn't donate because they had their own health problems. Beaver was not doing so great on dialysis. He eventually, after waiting a long time, got a long kidney, right? And the kidney is working, but it didn't work right away. The blood sugar in the hospital because the diabetes was high. Eventually, the blood sugar was controlled, and then that patient, because the high blood sugar, gets a wound infection, needs to have the wound open up, a sponge dressing placed on it. It's a lot more work at home. The nurse now has to come and help change the dressing 3 times a week. Kidney's not working yet, so there's a biopsy 10 days after surgery. The kidney's just sleepy. That's what that ATN means. And then a month later, the kidney's still not quite working. There's a little more urine coming out, but the numbers are not right. And so there's another biopsy, still says sleepy kidney. Maybe they switch the medicines around a little bit at that point in time. The patient stays on dialysis for another month after surgery, gets labs done all the time. And at 7 weeks, so almost 2 months, finally the numbers are looking okay and they can stop dialysis, right? But then the kidney works all right, but then turns out that a few weeks or months later, maybe Beaver gets admitted for heart failure now or volume overload and needs to start some medicine to get the volume out, and that makes the kidney numbers go up again. And so it's sort of a iffy struggle of a course, right? Let's see. Patient C, I named patient C Chris. Chris had kidney failure from high blood pressure, got a living donor from their sister. Surgery went well, did great on the first day after surgery, had a normal ultrasound. The next day, the legs get all swollen. The next day, the whole body's all swollen. The next day, they find a whole bunch of protein in the urine, and they were like, oh, this is a funny kidney disease. And now they get a biopsy. And the biopsy shows this disease called FSGS, right? And they thought they had just high blood pressure, but it turns out maybe in the beginning they had this disease called FSGS. And so FSGS is treated with a process called plasma exchange or plasmapheresis. Some people call it PLEX. And it's as much work almost as getting dialysis, right? And so people need their plasma switched out for other people's plasma to try to get this kidney to work. And so now we've traded dialysis for something actually much more complex. And I don't know if life is much better, that way or not. So I think that sort of, for me, describes the variability in patient experience in the first transplant. Protein in the urine shows up in the labs if you leave a urine sample and if they're checking for that. So that's how that works. All right. 10 months with a kidney and spent a weekend in December because of inflammation, got some infusion. Is there something to reduce the protein and creatinine? The protein and the creatinine, ratio in the urine, there's not one medicine to reduce it. Some people can take what's called these ACE inhibitors, lisinopril or captopril or whatever. Lisinopril is probably the most common. Those are ACE inhibitors, and they can lower how much protein is in the urine, but they also interact with the calcineurin inhibitors, so the cyclosporin or the tacrolimus that you take. And so, it's a very careful balance about should you do this, should you not. And the other thing that we worry about when there's protein in the urine is this. We used to call it chronic rejection, but now people call it antibody-mediated rejection. But other people who have diabetes, for example, you're just going to have protein in the urine, and there's not a whole lot to do about it. Some people take fish oil for it, I guess. So if we could never have protein in the urine and not ever have rejection, we'd have it made, but we're not so perfect quite yet, right? All right, now I'm going to stop the share again, because I think after having those 3 patients, right, it's always nice to learn a little more about each other. Can you start with IgA and then go to FSGS? Yeah, it does happen that you start with IgA nephropathy and people think that that's what you have, right? And then it turns out when you get a new kidney, you get FSGS. Some people get FSGS later, but very rarely does that happen. So for me, they thought I had post-streptococcal kidney problems. And in the end, they did a biopsy many years later on the new kidney. And they were like, no, you have IgA. And I'm like, oh, okay, now that makes sense. That makes sense too. But they couldn't find it in my kidney before I had my first transplant because it had turned to so much scar that all they saw in biopsy was scar. And once it's scar, it's scar. So that's why not everyone gets a kidney biopsy before they get a transplant. Cool. No, Sam, like your creatinine's 1.4 to 2.1. So yeah, you have chronic kidney disease, right? But you're stable. You may eventually, if you live many long years yet, need a kidney to follow. But so long as it's stable and staying like that for 6 years, and it might stay for a longer time yet. All right. Now, I want to know who of you most identifies with patient A. Went for my transplant. Everything went awesome. You guys get the hearts. Some of you in the reactions, right? Some of you are going to probably identify more with, a patient B where everything was just a struggle for a long time. And then eventually now I'm actually good and thankful that I had a transplant. You guys get the thumbs up. Okay. So we have hearts for everything went great. We have the thumbs ups for, it took a while, but I got there eventually. And then I think we have the, oh, yeah. And whereas things really just didn't go as planned after transplant, right? Either the kidney or the liver had a blood clot, you needed a whole nother one or something else fun. You found a whole new disease that you didn't know you had and all that sort of stuff. I personally, for my first transplant, was a thumbs up. It was a tricky one. I was in the hospital for a long time, had 3 rejection episodes. They didn't think that kidney was going to work a long time. Whoops. Someone should mute themselves. Josephine. There you go. Perfect. Thank you. And then my second transplant was more of a heart, where like I went home 2 days later. The kidney was great. Everything was perfect and hunky dory. And that was awesome. Every has its own way. And every one of us has their own story. True? But in the end, you know, years after, right? Usually most people walk away going, all right, that was a chore, but I'm still around, so it's okay. I'll get, you know, and we got over it. I think that makes us maybe a little bit tougher and different than the other patients. Cool. Awesome. There's some questions in the chat. Can you touch on CMV and BK? Sure, we can talk about CMV and BK. That is not a problem. BK, oh, mine was Dr. Schweitzer. BK, and my first one was Klaus Möhring. He was a troublemaker and I loved him to death. He's probably the reason I ever became a transplant surgeon. He was a urologist by training and just as much trouble as could be. So anyway, BK and CMV are viruses, right? And in transplant, we take these medicines, right? Immunosuppression, tacrolimus and myfortic, I don't know, or Cellcept, mycophenolate, whatever mycophenolate subvariants, right? We all know the names of them. They all have two names, right? A real name and a fake name. We take prednisone, right? Or some other steroid. What else do we take? Any of the olimuses, sirolimus, everolimus. Some of you may be taking belatacept or whatever. But in any case, the key parts of these medicines are that they're designed to weaken our immune system, okay? And specifically, they're designed to weaken our immune system that evaluates our own cells, okay? And usually our immune system, you know, these little white blood cells, they float around in our body, they go outside the blood vessels, and they sort of are like the cops, right? Or the army that sort of supervises and checks everything's okay. And all of our cells have markers on them, little tiny flags that say, yes, hi, I'm a normal cell, I'm happy, I'm healthy, everything is good, okay? And when a cell gets infected with a virus, it can do one or two things. One, some cells can take that virus and show it as a flag outside and say, hey, there's a problem here, help me, right? Like it's so hanging a red flag on your house. And now when the white blood cells come by, they see this little red flag on your house and they're like, oh, there's a problem here. We should knock and see what's going on, right? And if the white blood cells see the virus, they're like, whoa, 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 this is not good. Let's tear this house down and build a new one, okay? And that's what prevents cancers. That's why we get more skin cancer, right? Because when there's cancer, there's a little red or yellow flag hanging out there too, saying this cell's not healthy. Normally the immune system then destroys it and says, we'll build a new one, take this one out. But when you're taking these immunosuppression medicines, then your white cells cannot see these flags as well. They're blinded a little bit, right? And when they're blinded, they overlook it and we get a little skin cancer, or we get a little virus. And so most healthy people have normal cells that float around and they see these flags come up and they just fight them. Because we don't, we're more susceptible to virus infections, especially, right? And so that's what happens. And so there are these viruses that normal people don't get sick from. BK is a virus that most people have had when they get older. It's named after the first patient where they discovered it in. Their initials were BK. That's what it means. My kid, he's annoying. He sings this song. It drives me crazy. He goes, BK, have it your way. And I'm like, no, shh, 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 quiet. I don't want that virus to have it its way at all, right? So he thinks it's funny. And I'm like, just zip it. So in any case, so the BK virus can happen and that can live in the kidney and in the bladder and in the urinary tract. And if it moves up into the kidney and it infects the kidney, that kidney, you know, can get infected with this virus and it can have a kidney infection with just virus and that can hurt the kidney and kill the kidney. So the only real treatment for it is to lower the immunosuppression. But if you lower it too much, then you get rejection, because now your white blood cells can see that the kidney tissue is foreign. And instead of just fighting the virus, it fights the kidney. So it's a tightrope walk, right? Too much immunosuppression, the BK gets the kidney. Too little immunosuppression, the immune system kills the kidney. And so some people, if you find it early, are lucky, and they're able to find that sort of narrow space in which the balance is good and the kidney pulls through. In some cases, that virus comes on so acutely that, by the time you find it, the kidney is on a path to destruction that can be irreversible. So I hate that virus with a passion. And then CMV is a virus that also most people will get by the time they're 80 years old. Most of us will have had CMV, and it's not a virus we think about, right? It's like the common cold, doesn't do much to most people. But CMV actually, when it infects a cell, is very sneaky. It says, don't put any flags on your door. Don't put your normal home flag there. Don't put the infected flag there. Just take all the flags down. We're not flying flags anymore. And so the immune system can't tell that either. So it's a very sneaky virus, okay? And so because of that, the CMV virus then grows. Now, I have learned over time, the CMV virus is really sneaky in transplant patients. It can go anywhere it wants, okay? It can affect any body part that you can think of. Now, most common, it gives people diarrhea, right? And they get colitis, your colon gets infected with it. But it can cause hepatitis. I had it in my liver. I had hepatitis from CMV, very mild, very mild. They threatened to biopsy my liver, and I said, you leave that alone. It can cause, encephalitis. It can get in your brain. It can cause pneumonitis and get in your lungs, right? It can go anywhere and cause an itis. Itis just means inflammation. So CMV is a booger. Most people get CMV prophylaxis because CMV stays in your body. It never goes out. Okay, it stays there. So most people, when they first get immunosuppression or get treated for rejection with high doses, we treat the CMV virus as if it's there to make sure it doesn't grow and come. And then as the immunosuppression levels drop and things are not so bad, we take people off these medications. And so most CMV infections happen between around 6 to 9 months after transplant, because that's when we stop those medications. Cool. So yeah, those viruses are sneaky, but the key to preventing them is usually just to have the right amount of immunosuppression and not a little too much or too little. Lots of good questions. What are the signs that kidney disease is becoming acute? You're in trouble with kidney disease for your vowels. A, E, I, O, U. Okay. A means too much acid in your body, right? So you feel like you've went on a long run and your legs just hurt. It's too much acid. E is electrolytes, so it's your potassium. Your phosphorus is getting out of whack, that kind of stuff. Your calcium's low, your phosphorus is high. I is intoxication. So you can poison your kidneys acutely by drinking like tincture of wintergreen. Don't drink it, bad idea. O is volume overload. So too much volume in your body means either your legs are swelling or your belly is swelling or you're getting short of breath. You get short of breath when you walk or when you go upstairs. That can be a sign of kidney failure. And then that's overload. And then the last is U. That's called uremia, or a high BUN level in your blood. And that high BUN, when it gets above 80 or 100 or 150, most of us don't think very well anymore. So it's uremia is the other one. And those are then reasons to start thinking about doing dialysis. So, someone says my sugar was 99 and I want to be on top of it. Should I check it? No, I have high blood sugars when I go for my morning labs too. And so I actually just went to my primary and said, my blood sugars are 105 or 95 or like not quite right when I checked them. And I had them just check, you can check in your blood this thing called hemoglobin A1C, and it checks to see how your average blood sugar has been for the last 3 months. So all you need is to talk to your primary and say, I think I have some randomly high sugars. Let's just check to see there's no diabetes, and then you'll know. So that's good. Someone's living with HIV, no real issues, and now immune suppression. That it's funny because the HIV is a funny disease when it comes to kidney transplants, is that you think that it's human immunodeficiency virus. You have a weak immune system, and you do. But when it comes to transplant, that immune system somehow loves to look for kidneys and reject them, loves to look for other organs and reject them, livers too. So we actually have to be careful when patients have HIV to make sure their immunosuppression is high enough so that the immune system doesn't look for the organ. I think it's weak in one area, but then stronger in the part that rejects organs. Because the immune system, you have to think of it as sort of the national defense system. And in America, we don't just have the Army, but we have the Navy, we have the Air Force, we have the Marines, we have the Coast Guard, we have the SEALs, I don't know, we have the Space Force, right? Like we have all these different branches of the military, and your immune system is very much similar, right? It has T cells, it has B cells, it has innate immunity. And then all of these have like many, many, many sub branches and special units. So your immune system, if we weaken one part, the other parts sometimes overcompensate to try to make up for it. That's what keeps us alive. So it's a good thing. Don't be mad at your immune system. It's good that we have it. If we don't have it, we would all die as young children. Okay. There are diseases like that. But on the other hand, it's a delicate balance. Neuropathy can happen from so many causes, and it's annoying. There's nothing to do about it that I know of that fixes it. And that's good. People are seeing dermatologists. I like that. Skin cancers are common for life after transplant, right? And some people have high uric acid. I know high uric acid, curiously, right? If you study history, Ben Franklin said, I'm just a crotchety old man with gout. It turns out that gout is often, or high uric acid is often, an early sign that there may be someone going or heading into kidney failure. And so it's a very sensitive test. It's not very specific. But it may just be that, you only have one kidney and your uric acid level is a little higher than others. And so if it doesn't, if nothing changes the diet, there are some medications that you can take, and you can ask your doctor about those. So the uric acid usually, would cause gout. All right, perfect. All right. Yeah, yeast infections are similar to viruses. It's the same part of the immune system that fights it. Somebody had PTLD. Epstein-Barr is another virus, like somebody says, right? And that virus does sometimes turn into a lymphoma called PTLD, but it's not common. It's very rare. And depending on how early you catch it, it's reasonably treatable. So it's good. Would famciclovir help for the viral infections? It's one of the antivirals that we use for CMV. But it doesn't help for all viruses. Each virus is different, right? And so if you think about HIV as a virus, and there are very specific medicines that treat that. Hepatitis C is a virus. There are very specific medicines that treat that. The viruses are so manifold that there's not one antiviral that treats all viruses. So it's a very, very fascinating group of diseases. You all need to have like my friend come and talk to you who knows all about viruses and infections. That'd be cool. All right, they're hired. How frequent is cognitive blunting on immediate res tacrolimus? I don't know. I'm not a pharmacist. But we see it some, and it probably depends on the level and the dose and, the other overall health of the body. TAC levels can fluctuate. I'm not a pharmacist, Sam. Sorry, SJ. You're going to have to wait for a pharmacist to come. They will explain that to you much better. All right. Perfect. I love all the dermatology screening. If you don't have a good dermatologist, get a dermatologist, right? I'm going next week, Friday, to see mine. Some people get diabetes after their transplant, and there's two medicines that are usually at fault. It's the tacrolimus and the prednisone. Those both are not so healthy for the pancreatic islets. I don't know. Marty and Michelle can't eat eggs since their transplant. I have no idea. I am like with one of my new medicines that I take, struggling a little bit with the carbohydrates, and I'm like, fine. So I skip carbohydrates, but I'm not gaining weight, and I'm like, great. I'm the thinnest person in my family. I like it. So sometimes just weird things happen, and it's hard to know. Someone wants to keep their kidney forever. What can you do? You can eat a healthy diet. You can be not overweight, right? If your weight is lower, the kidneys have to work less hard. That's a good thing. If your weight is lower, your risk for heart disease is lower. Those both help you stick around long. I've also found that like less meat I eat, the kidney numbers always look a little better if I focus more on vegetables. Will a biopsy hurt your kidney? Not usually, but it can. like everything in medicine, right? If you need a biopsy of your liver, of your heart, of your kidney, it means taking a piece of it, right? Sticking a needle, or in the heart, they have a little grabber where they just pull out a little piece. And anytime you poke a needle somewhere, right, it can hurt. I mean, you've all had blood draws, right? Sometimes you get a bruise and sometimes you don't. It's the same with a kidney biopsy, right? And if it's just a small bruise and it gets better, okay. But, you know, I've seen some people that really, really had significant bleeding and needed surgery after a biopsy. It's not common, doesn't happen often, right? And so the question is always, do I really have to have this biopsy? You know, if your creatinine goes up and then it comes back down, and now it's back to close to normal, the question is, should I just wait another week and check blood work again before I do a biopsy? But if your creatinine goes up and you don't biopsy it and you don't know that there's rejection there, you could lose the kidney forever. So the reason we do biopsies is usually a sound enough reason that there's no other test that will tell us if your kidney is still safe. We're always looking for new tests, you know, these ideas of liquid biopsies, i.e. checking your blood levels to see if there's a rejection in your organ. That's coming, and we're using it more and more. The tests are not perfect yet, but we're learning. I love this. This is all interactive, just answering questions. We're completely not using slides. I like this better, actually. Perhaps your donor didn't like eggs. That's so funny. If some can true. Someone says, what are the signs of diabetes? Usually the signs of diabetes are the three P's. So polydipsia means always being thirsty and wanting to drink, and drinking gallons of fluid. Okay. The next sign of diabetes is polyuria, i.e. you're making a lot of urine, a lot of urine, like you're always running to the bathroom, peeing. And then the third sign of diabetes, that's the classical, is polyphagia, which means you're so hungry, you're always eating, because normally your diabetes then can't control, your pancreas can't use the sugar that you eat. And so your body feels always hungry, right? Now, there's different kinds of diabetes. There's not just type 1 or type 2. There's all kinds in between. And with those kinds of diabetes, the symptoms can be different. So usually, but you all as transplant patients probably get blood work, you know, so the best sign of diabetes is looking for your blood sugar, right? And if that's higher than 120, 140 on multiple occasions, you should be checked for it. And you can also look for protein in the urine. If normal, healthy people have protein in the urine, it can be the first sign of diabetes or other kidney problems. Cool. Future of immunosuppressants. Yeah, I don't know. It's so funny. It's a great question, actually. Matt's asking what new immunosuppressions are coming. And I'm like, I'm not sure a whole lot new will come. And the problem is that when we only do so many transplants per year, right? Out of the many transplants we do per year, we need many of them to do really well to keep going. And so whenever we do studies and we want to test a new immunosuppression, you know, a lot of companies want to test them only in patients who get a first-time transplant who don't have these other problems, or they want to test them in second-time transplants only because we think it's better in this scenario. And so then to study it at only one hospital becomes difficult, right? Because you don't have enough patients to study it on, right? And then when you only can enroll a small group of patients at one hospital, you have to do what's called a multi-center study and get all the hospitals to participate. And they cost so much money that it's not so worth it for companies to invest in newer immunosuppression. So I think right now the focus is on figuring out when organs are failing or when they're at risk for starting to fail earlier. And then hopefully if there's a test that can figure this out, the question will be, what can we do to treat it? But I think we need to learn a lot more about what causes these early changes from a normal functioning transplant to starting to fail. Is it immune system related? Is it just that the organ's getting older? What's the problem? And then hopefully eventually we'll look at, ways to treat that. When people take their meds the right way, and everything is going well, very few people have real rejection problems, right? So that's cool. You all have so many questions. This is cool. When you have your heart biopsies, take another little piece of my heart now, baby. I love that. Yeah, we have the same sense of humor, Mike and Linda, because we do silly things like that in the operating room too. I was doing a kidney last night with a friend, and we said something and we started singing the same song at the same time. So You got to have fun while you do your work. What's the current status of COVID and kidney transplants? A great question. It depends, right? We now use kidneys from donors who have COVID. If there's no inflammation in the kidney and the kidney's working normally, there have not been any reports of transmission of that virus or people getting sick from COVID. We usually make sure that the recipients who get these kidneys are vaccinated though, because it just seems responsible, right? Different hospitals have different rules and regulations about insisting that their patients are vaccinated. Some people insist and some people recommend. So you might get different answers from different people there. And at the moment, I tell you, the best thing we have to protect from COVID is the vaccine, the booster, the bivalent booster, because the newer variants of COVID, the medicines we used to use to treat it when people got sick are kind of not working so well anymore. So we're back to good old remdesivir if we get sick with COVID. Or if you're like, sick and you're on very low levels of immunosuppression and you've been vaccinated all the way, you may or may not need the remdesivir, but most people give it because it can prevent people from getting sicker. The dyes used during biopsies can damage kidneys. No, you don't need any biopsy. Well, heart biopsy, I guess, yes, the IV contrast, but they can use sometimes carbon dioxide, CO2. And most of the contrast agents, if you need a CT because, they're worried of you having some bowel obstruction, they say you need some contrast, right? There are modern day contrast versions. So the contrast that we used 10, 20 years ago was really, really high in salt when we got CAT scans. And that high in salt contrast really took something out of the kidneys, and many kidneys had their creatinine go up and stay bad. The newer versions of contrast are not as bad for the kidneys. And when they do a heart biopsy, frankly, like they go in the neck and they don't use a lot of contrast. That's a very small dose, right? When you need an angiogram, a CT angiogram, that's a big dose of contrast. But I'll tell you that even us as kidney transplant surgeons will give that contrast if we think it's the safest study, to make sure a patient is safe from another problem, right? So if you are having a stroke and someone needs to make sure your blood vessels in the neck are open, the stroke's going to kill you before your kidney failure is going to kill you, right? And so in that case, you should absolutely say yes to the contrast. Same if you're having a heart attack and you come to an emergency room and they're like, we need to do a heart cath, we need to give you contrast. Well, I'm not going to die from a heart attack just to not expose my kidney to contrast. Does that make sense? Now, if someone says, well, I want to do a CT just for a fun study, I just kind of want to know, I'm like, why? That makes no sense, right? I don't want the radiation. I don't want the contrast. But it just sort of depends on, what possible benefit I can get from it. So I'm pretty liberal with it. I usually will say that, hey, I have a kidney transplant. I want you to use the fancy new kind of contrast, not the old stuff. Same for MRI. The MRI contrast is very different from the contrast that we use for CT. And sometimes people don't want to give that MRI contrast to people like us because they're like, your kidneys aren't perfect. And I'll tell you that the modern day gadolinium that we use for the MRI doesn't cause any problems with skin scarring at all. There's no case reports of it. It's never happened once. It's never been described once, and even in the literature, so long as they use the most modern version of the contrast, and most of them these days do. So like I have a lot of arguments with the radiologists saying, got to be careful. So yeah, read this, Patty Dash. It's not unheard of, that people are different based on what happens. So I don't know what it is that sometimes we turn into or start liking things that our donors like. I can tell you that I've always liked nuts and chocolate. I still eat nuts and chocolate. You are what you eat, so I'm crazy and sweet. And that's kind of how I am. But like some people think that there is something that can come from the donor and be a little more usually related to foods. How reliable are the tests? To detect rejection and avoid invasive biopsies is a great question. None of us really know. And we're trying to figure it out, right? And the truth is that even when you do a biopsy of the organ right now, it's not perfectly reliable. Think of it, my kidney is this big, right? If I have an infection in one half of the kidney, or one half of the kidney has died because of poor blood flow, and I biopsy that half, my kidney looks crappy. I biopsy the other half, it looks completely different. Same with infection, same with rejection. Not all rejection is all equally everywhere. Sometimes it's a spot, and a spot like a polka dot kind of pattern, right? And if you biopsy outside the polka dot pattern, you may not even see it. So even biopsies aren't perfect. So the question is, what's the gold standard of figuring out what's really going on? And so that's a great question, and nobody really knows. There you have it. Someone woke up craving string beans. I sometimes also wonder though if it's the steroids, because the steroids change your appetite a lot anyway. Chocolate much more, yeah. Is it okay to drink 64 ounces of water per day? Yeah, it's totally okay if you drink it every day. If you're normally just drinking 2 ounces of water and then you go to 64, you got to do that slowly, because that can lower your sodium. Otherwise, you can get a little low sodium crazy from drinking too much water all of a sudden. But in general, my rule of thumb is you drink until you're thirsty. To reduce side effects. Yeah, I wish reducing side effects. I wish they would all work towards, helping patients. I think everything these days is about money. It's not about us. So we have to advocate a lot. Let's see. Biopsies are generally pain-free if you're asked for drugs. Yep. I don't even get sedation for my biopsies. I just put local numbing medicine in. I tell them to put bicarb in my local numbing medicine, and I just don't even need anything else for a biopsy. It's great. Getting diabetes after transplant. As we age, some of us can get more diabetes as well, right? Especially if we're overweight. And then, like I said, the tacrolimus and the prednisone are not necessarily friends to your pancreas either. Yep, people are getting other screening tests. That's funny. Kidney of a 34-year-old female. That's funny, Kevin. But it happens, right? We change after transplant. Maybe we become more sensitive because of our experiences. Maybe we become more sensitive because of our meds. Maybe it's really truly from the kidney. I don't know. So, but that's cool. Kidneys made in laboratories. Oh yeah, pig kidneys and other kidneys. I really hope so. I can tell you that at the moment, even the pig kidneys that they're growing still look too much like pig. Right? So remember I told you about the houses that hang different flags out? Pigs hang like very weird flags out, okay? So like assume all the pig flags are like triangles and circles, and a normal flag is a rectangle, okay? And then normally in a human, they look different, because our rectangles like red or red and white striped or red and blue striped or orange and blue striped. That's ugly colors. Or plain old orange and black, that's tolerable. So like the human colors of the flags change, but the shape never does. And so when you go from one species to another, like pig to human or something, the flags are very, very different. And so in order to do that, the genetic modifications can sometimes, cut the flagpole short, or maybe make the flag a little more rectangular that's there. But our bodies are just so smart that they're really good at figuring out what's not us. And that's to keep us alive, to keep us safe from infections, to keep us safe from cancers. And so those other organs look like that. I do hope that as we keep doing research, we can figure this out. I think it's really, really hampered by the fact that research in this country has gone wrong. Research in the world has gone wrong. People have done illegitimate research on people, right? Without them should be doing that. And without people being aware. And so now our rules and regulations with the FDA and with the IRBs are such that research has to be done in the very safest way possible. It has to be done with the most consent possible. And if we want to do big leaps and bounds, they're very difficult to make that progress. So if you think back, right, in the 1960s and transplant started, right, 1954, and the first kidney transplant happened, 1966, the first pancreas transplant happened, I think maybe it was 64 in Minnesota, but there was no IRB, no institutional review board. They didn't need to do this pancreas transplant to have permission from a group of other researchers to say, we think this is right. They just took a patient with diabetes and they said, well, we think we can put a new pancreas in and they'll be better. Let's just do it. And they did it. And the first 10 failed. And then eventually they figured out how to work it. And now we can do pancreas transplants and do better with diabetes, right? Today, if we set up a study and said we try 10 pig transplants or we try 100 pig transplants and we'll see how people do, if the first 10 failed, that study's closed. We're all done. We're all done, right? And so it's good because it's safe for patients, right? Patients who got these pancreas transplants and they had complications died back in the 60s. But I think as patients, I mean, if I'm old and I know I could benefit from another transplant, but I know I have 10 more years to wait and I'm not going to live that long, I'd probably be willing to say, hey, sign me up for a pig. I'll do it. Either I'll die, but we've learned something from it and I'm cool with that. And so is my family, right? Or else, if it works, that's fantastic. We've still learned something from it and maybe we're helping other people. But that's sort of not a go anymore in today's day and age. And so I think, while it's super exciting, the progress is just slower because now we have to do a big study first from pig to monkey, right? Or from, I don't know, pig to cow, right? Or something before. And when that works really perfectly, then we have to pick the right patient and the right situation to maybe try 1 or 2 or 3 in actual humans, or do it in special situation, right? Where we now are experimenting with brain dead, humans that would normally be organ donors, and maybe they donate all their organs, and maybe one kidney that couldn't be used for another could then get a pig kidney transplant for a day or 2 after, to see how it works, because they're already dead. And so those rules don't apply because you can't now hurt a living being. So they're trying to always find sort of ways to keep moving the research forward, but it turns out that there are a lot of barriers, and they're intended to keep people safe and to not have any researchers do anything unethical or illegal to people. But at the same time, it slows down research, right? So you can't have perfect control over all research and perfect safety, and you can't have fast progress. And that balance, went from one to the other in the last 50, 60 years. So I think they're coming, but I don't know that it'll happen in my lifetime. I mean, I dream of it as a surgeon, right? Because if I just had pig kidneys to transplant, I could do 2 on Monday, 2 on Tuesday, 2 on Wednesday, send all my patients home by Friday and not have anyone in the hospital Saturday, Sunday. That's a dream come true. But I don't know that that'll realistically happen, right? So, all right. How often should we get a follow-up COVID booster? Every year. That's what they came up with. Nothing different for us than everybody else. Can high blood pressure cause too much protein in the urine in the long run? Yes. Via FSGS, but it's secondary FSGS, and there are different forms of that disease. Are there ways to get rid of contrasts out of your body quickly? Drinking fluid turns out to be going in hydrated, and staying hydrated is probably the best way to do that. Or unless, if you don't come in drinking, drink after, and then dialysis if not. Some people are allergic to gadolinium, then don't get gadolinium. If you have an allergy, stay away from it. All right, there you go. Eat nuts in place of red meat from heart transplant. Yep, red meat isn't necessarily heart healthy. You can always make exceptions, right? If it's your 25th wedding anniversary and you want a steak, I would make an exception for that, because at some point you have to have a life too, right? You can be good 90% of the time, but sometimes you have to have a life too. So I think this is cool. All right, it's almost 12 o'clock, Michelle and Marty. There's like a whole lot more to talk about. I guess I can come back and talk some other time.
Well, it's up to you. We have a lot of comments too. They're not all questions. I leave it up to you. If you have a couple more minutes, people telling you you're awesome. People just commenting on what they eat differently, and that as you ate. Yeah. And, but we're sorry for the hiccups we had earlier here, but, you're awesome. We know you can handle all these stresses and take care of it. And you did such a great job with just answering what people are interested in. Sometimes going off script is really kind of the best thing to do. And you did that. I think that was great.
Yeah.
So if anyone has a really important question, is it okay if I forward it on to you if they send it to me?
Yep. And a lot of times, it's general advice, right? And the key question is ask your doctor, because they know your health much better than I ever will. And so that's good. Bobby's asking, the slides will be posted. Marty and Michelle are going to post those slides. So thank you so much all for coming.
Well, we want to thank you, and we want to thank everyone for attending today. We love seeing you, Dr. Silke, and our guest. It's always great to see all of you. Check out our events pages on our website for advance notices for our upcoming meetings. Check out our website at www.triomaryland.org. All of our past meetings are posted on our YouTube channel for your convenience. And last but not least, don't forget to turn your clocks ahead tonight for daylight savings time.
So everyone,
All right.
you're still getting, you were fantastic.
I
It
know.
was
We could
excellent.
keep going for days. Thank you all for coming, okay?
Thank you, Dr. Silke, for your time and your expertise. We
All
really
right.
do
Y'all take
appreciate it.
care.
Thank
Bye-bye,
you.
everybody.